Hello, my name is Patty Doring and I'm a palliative care nurse consultant with Northern Health. I'm here today to talk to you about palliative care, and today's presentation will be from material prepared by Kath Murray and Joanne Thompson and is related to Kath Murray's book, Integrating a Palliative Approach, Essentials for Personal Support Workers. So the topic for today's presentation is based on Chapter 3, Integrating a Palliative Approach into Caregiving, and it is intended for support workers and care aides, as well as anyone else working with people who are dying. At the end of this session, I'm hoping that you will be able to understand and describe the concepts of palliative, hospice, and end-of-life care, to discuss the philosophy, principles, and practices associated with this care, to differentiate between empathy and sympathy, and to identify ways to create a safe, nurturing place. So I'll just go over a short history before we get started. Cicely Saunders is one of the founders of palliative care and one of the first people to advocate for and make changes in how we care for the dying person and their families. In 1960, Cicely Saunders, a social worker and former nurse, spent considerable time talking with a patient, David Tasma, about his concerns regarding dying and ways to improve care. She heard and saw that the needs of the dying were not being met in acute care hospitals. So she became quite passionate about this idea of providing care that would actually attend to these needs. And she went back to school, became a doctor, and proceeded to found the St. Christopher's Hospice in 1967. So she built the principles of the hospice upon the ideas that she and David had discussed, and this care focused on attending to the unique needs of the dying person and their family. So in the past 40 years, care of the dying has changed thanks to the work of Dame Cicely Saunders and many others. So in 1974, Dr. Balfour Mount established palliative care in Montreal after he studied with Dame Saunders, and he coined the term palliative. And this is because palliative translates better into French than hospice. However, in Canada, the terms hospice and palliative are used interchangeably or together and mean the same thing. Hospice palliative care generally helps to manage the symptoms people experience when they're dying, and the goal is to manage these symptoms to help improve the dying person's quality of life. So fewer symptoms equal greater satisfaction with their care as well. And some examples of these symptoms that you might see are nausea, vomiting, pain, difficulty breathing, confusion, restlessness, or delirium, changes in bladder and bowel function, fatigue and appetite changes, as well as weight loss and mouth discomfort. So people can benefit from palliative care from the time of diagnosis, as it can help to provide information regarding the disease or illness and its process. It can help with advanced care planning and care options that are available, as well as emotional or psychosocial support. And this can help them to be a lot more prepared to deal with the emotional and physical issues throughout their journey. So palliative care is not just for in the last days or weeks of life. It can work together with curative care and provide support and a better quality of life for people with a life-limiting illness. An example of this would be a person who is diagnosed with liver failure and is waiting for a liver transplant. So this person could receive palliative care treatment for symptom management during this process. Around the world, hospice palliative care is based on a common philosophy of improving the quality of life for dying people. So palliative care is care that affirms life, regards dying as a normal process. It considers the dying person and the family to be a unit of care, as well it continues through death and bereavement. And palliative care promotes care that improves the quality of life. It doesn't speed up or delay death. It provides pain relief and management of distressing symptoms, as well as attends to the dying person in a holistic way. And research shows that even though we can't necessarily delay death, an early palliative approach actually can help lengthen someone's lifespan. And symptom management enables a person to tolerate certain treatment longer because they actually feel better. And in some cases, it has been reported that people have even lived a few months longer because of this. Unfortunately, less than 30% of people who are dying receive palliative care. There are a few specialty teams out there, and they are mostly located in urban areas. So location can limit supports in certain areas such as rural or smaller centers. As well, there tends to be a bit of a fear of the word palliative, as well as a lack of knowledge or unwillingness to learn about palliative care or even acknowledge it. And the importance of palliative care is now being brought out to the public through physicians as well, with an increased focus on palliative care education. Also, palliative care is mostly accessed by people with a steady, predictable death. So, hospice was originally aimed at the needs of those dying of cancer or only needing treatment in the last few weeks or days of life. But there are changes in the way that people die now, and people are actually living longer. So, predictable deaths really now only account for less than 20% of deaths. So, the solution, palliative approach. Australia has actually integrated palliative care into their primary healthcare system. This helps to really expand the reach of hospice palliative care to the public and offers a palliative approach by all those involved with care. As well, it's supported by input from specialists when necessary or for developing resources as well. And the definition of a palliative approach for the purpose of this book is integrating the principles, practices, and philosophy of hospice palliative care into the care of people with any life-threatening disease early in the disease process across all care settings. So more people are living longer, and they enter long-term care later in their disease process when it's more advanced. So in some cases, the length of stay is actually shorter. In Canada, the average length of stay is only about 18 months from 2014 statistics. And because the length of stay is shorter, there are more deaths each year in long-term care. So for most people, long-term care facilities will be their last home. Integrating a palliative approach into long-term care will improve the care of the dying. The management of symptoms helps prevent visits to the emergency room, as well as the possibility of unnecessary treatments that may not be beneficial, may cause increased stress, and can possibly be more harm than good. And this in itself helps to improve the quality of life in their remaining days. A palliative approach works well with dementia care principles as well. It offers consistency of care and helps to support their dignity. It's always beneficial to start individual-based care early so that you're able to give the care that's best suited for the dying person. And just as a palliative approach can help people who live and die in long-term care, it can also help people who are admitted to the emergency department or medical unit or anywhere else in the hospital, as well as those who are living at home or in their own homes. For simplicity in this book, Kath Marie uses the term end-of-life care to refer to the last days and weeks. So depending on where you work, this may be different. So be sure you know what is meant by end-of-life care in your facility. We tend to label people as palliative, but palliative is actually a type of care. So consider using these phrases instead to refrain from labeling a person as palliative. You could say, he is in his last days and hours, or she is actively dying. The healthcare team. So the dying person and their family are the focus of care, and the support worker or care aide holds the family in a safe, warm embrace. But remember, this embrace must not be so tight that the dying person and their family cannot do the necessary work on their own behalf to grieve and make decisions. So the key principles of the care team are that the dying person and the family are the unit of care, and the support worker and care aide holds and supports the person and family. And by holding, we're suggesting creating a safe place. And the support worker and care aide is supported by their colleagues. The larger team is less visible, and the team needs to communicate to be effective. So the support worker and care aide has to communicate information from the dying person and the family to the team. So communication to the team in regard to changes or symptoms is very important in maintaining the continuity of appropriate quality care. The health team varies, and location is a really big factor in what your care team may look like. So whether it's urban, rural, in a care facility, or even at home. As well, it's also important to consider people's individual care preferences depending on their comfort level. So some people are more private and prefer a smaller care team, while others are appreciative with having different people being involved with their care. And as care aides and support workers, you integrate a palliative approach by holding the dying person and the family at the center of care, by gathering information, by observing, listening, asking, reflecting, and responding, as well as considering the needs of the whole person, providing physical and psychosocial support by implementing the care plan and individualized comfort measures to communicate and advocate for that dying person and their family. So a bit of an interesting concept regarding good death and bad death. This is interesting because everyone has different ideas or opinions as to what is a good death or a bad death. Someone might say he had a really good death, or you might hear someone else say she had a bad death. People see good deaths as being pain-free, sudden, or during sleep with family surrounding them, or sometimes even alone or at home, sometimes in hospital. So it's quite varied, as well as a bad death can be seen as suffering, painful, prolonged, noisy, alone, but it can also be in hospital or sudden. So as you can see, they can sometimes be the same or different, and these can also depend on the individual's religious or cultural beliefs as well. But really, these are only subjective or descriptive terms, and what we want to strive for is a death that meets the needs or preferences of the individual so that they die in a way that is dignified for them. And the aim should actually be for an appropriate death according to that person who is dying. A death with dignity where the needs of the individual who's dying are identified and addressed to the care team is what is important. As well, everyone has a different approach and caring manner when providing support. So as care aides and support workers, you provide support by helping to create a nurturing space. And to do this, you need to be real, to express empathy, to avoid communication roadblocks, to be able to offer a compassionate present and support dignity, and to communicate effectively. And in being real, you would offer supportive care, be genuine, compassionate, and considerate, as well as professional. Empathy versus sympathy. So empathy opens the door for effective communication with the dying person and lets them express themselves. So it's about being with them and listening and acknowledging their experience, where sympathy tends to close the door to communication and is more focused on the person who is actually offering the sentiment. So sympathy may not allow them to express themselves or to communicate concerns or fears or deal with their dying or their grief. It may even lead to their inability to cope as well. Avoiding communication roadblocks is also important, and communication roadblocks are phrases or responses that also shut down communication. They can minimize issues and lead to people feeling like they're misunderstood or not being heard. So that would be saying something such as, it could be worse. Offering false reassurance such as, it will be fine, does also not address the worries or anxieties that people may be experiencing. Avoiding platitudes such as, the grief will pass. Truth told with compassion is most helpful. Praising too often or too much can cause them to feel unable to ask for help when they are feeling lost or fragile. So by saying, you are so strong all the time. Roadblocks make it more difficult for a person to express themselves. So listen and acknowledge problems and difficulties and be present. As well, you can also run the risk of falling into a fix-it trap. So you may be in a fix-it trap if you feel that your job is to fix things, but we cannot always fix deep and emotional and spiritual pain. So in the fix-it trap, we only hear what needs fixing, and we may avoid caring for someone when we cannot fix their problem. And the fix-it trap may lead to judging or labeling. So if we label people as being difficult, we may avoid speaking or caring appropriately for them. So you may hear or see and only focus on the problems that are easy to fix. However, our job is to support and not always to fix, and just to be present and to listen. As well, labeling people doesn't allow you to identify the problem really, because sometimes the problem may be deeper than we actually know or see, and they may be unable to express themselves as well. So offer a compassionate presence. When you work with the dying, you will be in the presence of suffering. So be present, not always talking, but listening. And be compassionate, which requires the inner disposition to go with others to the place where they are weak, vulnerable, lonely, and broken. And on being compassionate, our greatest gift is our ability to enter the solidarity of those who suffer. So talk to them about what they're going through, or even just listen to them talk about it. And working with people in a crisis is similar to reading Braille, and you need to just feel your way moment by moment. As a support worker in care age, you need to be able to put aside your agenda and actually be with the dying person, even if it's just for a few minutes, to just sit and breathe and feel your way. And in being with, breathe in an easy, natural rhythm and allow for silence. And so how can silence help? Silence is full of presence for the dying person and their family and is an important part of communication. It makes room for whatever needs to happen. So if you present silence, you just have to trust that what needs to happen will happen. And how can you best support the dignity of the dying person? So the way a person sees himself is by how others see and treat them. And dignity and respect is shown to the dying person and their family by how you treat them and how you make them feel. So one of the best ways to support their dignity is by asking the dignity question. What do I need to know about you as a person to give you the best care possible? So this one question can help you identify and attend to the needs and wishes of the dying person and how they actually wish to be cared for. Make sure, though, that if you write down their wishes, be sure to ask if they would like a note put on their care plan or chart for the other care workers to see and to understand when providing care. Ask the dignity question when the person first arrives to care, as the care progresses, and with any transitions that may occur, as the person's needs may actually change throughout their journey. And this can really make a big difference in the way that you approach and care for the dying person and their family. Then you need to ask yourself as well, are you actually meeting the person's needs and taking what they expressed into consideration with the care that you are providing? People need to communicate as well. Communicate or be eaten by your affliction. The opportunity to express themselves verbally and non-verbally is very important. Communication is the expression of a person's experiences and needs, and communicating can bring change. Support workers and care aides that provide a safe place for communication will allow the person to grow as they die, and it also allows for growth within the family as well. By using open-ended questions, you can encourage conversation. So by asking what is happening, or if they can tell you more, or explain, or give an example. Open-ended questions allow a person to share their story and allows you to see and hear what their story is about. This enables you to validate their experiences as well as helps prevent misunderstandings. And it helps to invite or promote communication without judgment. Using open-ended responses may also encourage further exploration with non-judgmental reflective responses and helps gain clarity and understanding of the dying person and their family. Open-ended response would be something such as saying, I wonder if what you are saying is, and then paraphrase what they've told you. Or, so I get the sense that, and then, is that right? So really paraphrasing and reflective responses help to prevent any misunderstandings that can and may occur with communication. So the team at base camp is an idea that comes from Kath Murray's textbook. And it's based on John Arnott, a mountaineer, who was the principal organizer and leader of the first team that climbed Mount Everest. And when he spoke in Victoria years later, he stated that he was only able to reach the summit because of the team at base camp. In palliative care, the healthcare team provides support at the base camp, and you are a part of this team. You care, support, connect, communicate, and advocate on behalf of the dying person and their family. So you create a safe place for them when you are genuine, express empathy, open the door to communication, provide a compassionate presence, and are comfortable with silence. You support the dignity of the dying person and can best meet their needs when you ask, what do I need to know about you to provide the best care possible? With a safe, supportive base camp, the dying person and family are able to grow during their suffering and live more fully through the process of dying and grieving. So, in summary, I hope that you now understand and can describe the concepts of palliative hospice and end of life care and are able to discuss the philosophy, principles, and practices of this care. And that you know the difference between empathy and sympathy and are able to empathize more readily, as well as able to identify ways to create a safe, nurturing place for people who are dying and their families by being present, genuine, compassionate, and by communicating effectively with your team. I would like to thank you for taking the time to listen today. If you have any questions in regard to this material or anything else, please do not hesitate to contact the Northern Health Palliative Care team. Thank you.